Welcome to class, everyone. Today we are diving into an absolute masterclass of human physiology. We're talking about the Renin-Angiotensin system, or just RAS for short. Now, if you're a complete beginner to pharmacology or how the body works, honestly, do not worry at all. I'm going to walk you through absolutely every single detail of this incredible biological pathway. We'll look at what it is, the systems it uses, and the different drugs that act on it. By the time we wrap up this explainer, you're going to understand RAS so deeply that you will literally never forget it. Let's get started.
So let's kick things off with a literal life or death question. Just imagine, heaven forbid, you are losing fluids rapidly, or your blood pressure suddenly plummets. In that terrifying split-second moment, how does your body instinctively know how to save you? What is the emergency backup system that kicks into high gear to make sure your vital organs keep getting blood? Well, the answer is the RAS cascade.
Here's a quick look at our syllabus for today's explainer. We're going to cover 1. The blood pressure thermostat. 2. The RAS assembly line. 3. The mastermind of the system. 4. The pharmacology blockade. 5. ACE inhibitors versus ARBs. And finally, number 6, a big picture summary.
All right, let's jump right into part 1, the blood pressure thermostat. Now, to fix low blood pressure, your body actually has to realize the pressure is low in the first place, right? So the real hero here is this tiny, brilliant biological sensor tucked away in your kidneys called the juxtaglomerular apparatus. I know, it's a mouthful, but just think of it like a highly sensitive security camera. It is constantly monitoring renal perfusion pressure, which is really just a fancy way of saying how forcefully blood is pushing into the kidney. It's also watching the amount of sodium flowing through your distal tubules. The second it detects a dangerous drop in pressure or a sudden lack of sodium, it sounds the alarm. And how does it do that? By releasing a specialized protein, or proteolytic enzyme, called renin. Basically, renin acts like a pair of chemical scissors floating right there in your bloodstream.
Moving right along to part 2, the RAS assembly line.
Okay, so once renin is released from the kidneys, it travels through your blood and bumps into a plasma protein called angiotensinogen. Now, your liver is actually constantly manufacturing and releasing this angiotensinogen. So renin takes those chemical scissors we just talked about and literally snips a specific piece off of the angiotensinogen. What you're left with is our intermediate product, a decapeptide, which just means a chain of 10 amino acids, and we call this angiotensin 1. But here is the critical thing you need to remember. Angiotensin 1 is basically inactive. It doesn't really do anything on its own. It's just raw materials sitting on the conveyor belt waiting for the next step.
And that brings us to the most crucial conversion in the whole system. As that inactive angiotensin 1 is just floating along through the bloodstream, it runs into an enzyme called ACE. That stands for angiotensin converting enzyme. Now, ACE is mostly hanging out in the tissues of your lungs, and it works incredibly fast. ACE snaps 2 amino acids right off of angiotensin 1, transforming it into our final, highly active product, an octapeptide, or an 8 amino acid chain, known as angiotensin 2.
Let's just take a moment to look at how beautifully this whole factory line comes together. You can really see how the raw materials combine. Renin from the kidneys meets angiotensinogen from the liver right there in the bloodstream. You'll also notice that your sympathetic nervous system, your body's classic fight or flight response, can actually trigger this renin release to prep you for action. Meanwhile, a peptide from the heart called atrial natriuretic peptide acts like a brake to slow it down. It is just this perfectly balanced biochemical assembly line, and it all leads to the creation of angiotensin 2.
Which perfectly sets up part 3, the mastermind.
You really have to appreciate the sheer raw power of this tiny 8 amino acid chain. I mean, you might already know that noradrenaline is a massive driver of blood pressure, right? Well, get this. Angiotensin 2 is roughly 40 times more potent at spiking your blood pressure. 40 times! It is an absolute powerhouse of a molecule. So how exactly does it manage that massive pressure spike? Well, it binds to what we call AT1 receptors, and basically launches a multi-pronged attack. First, it causes generalized vasoconstriction, which means it vigorously clamps down on your blood vessels, especially the ones in your kidneys. Second, it triggers even more noradrenaline release, tightening the whole system further. Third, it marches over to the adrenal cortex, that's the outer layer of the adrenal glands sitting like little hats on top of your kidneys, and forces it to secrete a hormone called aldosterone. Aldosterone tells your kidneys to aggressively hoard salt and water. And think about it, more fluid volume crammed inside tighter pipes equals a massive spike in pressure. Over time, it even stimulates the growth of cardiac and vascular cells to physically reinforce those pipes. It's truly amazing.
Let's pivot to part 4, the pharmacology blockade.
But what happens when this life-saving assembly line gets a little too enthusiastic and becomes dangerously hyperactive? In conditions like chronic heart failure or severe hypertension, the body gets constantly flooded with angiotensin II. This overworks the heart and actually damages the blood vessels over time. So when the system turns against us, we have to send in the saboteurs. Scientists have invented specific classes of pharmacological drugs to block this exact cascade at very specific points. It's literally like pulling workers off the assembly line. For instance, we can use a drug called aliskiren to inhibit renin right at the very beginning. Or we can use ACE inhibitors, like captopril and enalapril, to stop the creation of angiotensin II entirely. Alternatively, we can use ARBs, like losartan, to block the AT1 receptors, meaning angiotensin II gets made, but it has absolutely nowhere to bind.
When we deploy these targeted therapeutic roadblocks, we are intentionally interrupting that dangerous domino effect. By blocking the cascade, we reduce the overall fluid volume and vascular resistance in the body. That lowers the heavy workload on the heart, stops the aggressive clamping down of the blood vessels, and ultimately effectively lowers the patient's blood pressure. It is honestly one of the great triumphs of modern cardiovascular medicine.
Now for Part 5, ACE inhibitors versus ARBs.
If you're going to take away one pharmacology lesson today, understanding the difference between these two heavily prescribed drug classes is absolutely essential. Here is the crucial distinction. ACE inhibitors like captopril stop the production of angiotensin II completely. But there's a catch. The ACE enzyme also has a day job breaking down a substance called bradykinin. So when we block ACE, bradykinin starts to pile up, and that accumulation physically irritates the patient's lungs, which very often causes this really troublesome persistent dry cough. Now, ARBs, often called the sartans, like losartan, take a totally different route. They just block the AT1 receptor itself. Because they leave the ACE enzyme completely alone to do its job, bradykinin doesn't build up at all. So they cleverly bypass that annoying dry cough side effect entirely, while still getting the job done and lowering the blood pressure.
Which brings us to our final section, Part 6, the Big Picture Summary.
All right, class, we've covered the physiology, the cascade, and the pharmacology. Let's cement this so you never forget the elegant flow of this timeline. A sudden, dangerous drop in pressure triggers that juxtaglomerular apparatus to release renin. Renin then snips angiotensinogen to create inactive angiotensin I. Next, the ACE enzyme hanging out in your lungs quickly converts that into the ultra-potent angiotensin II. And finally, angiotensin II acts on its receptors to clamp down your blood vessels and retain salt through aldosterone, ultimately restoring your blood pressure and saving your life.
Given how deeply this single, beautifully complex pathway controls our vascular destiny, from our moment-to-moment survival all the way to long-term conditions like heart failure, I want to leave you with this final provocative thought. As we continue to discover even more about the tiny nuances of this biological assembly line, how might we eventually engineer the ultimate cardiovascular cure? Keep studying, keep asking those big questions, and I'll see you in our next explainer.